So let us move to the next debate, which is as we go forward. So traditionally in health professions education, we've used block rotations to satisfy our clinical training settings. However, in medicine and some other professions, there's a begin to move towards more longitudinal integrated curricula. And these have their proponents and they have their detractors. Most of the detractors are in the realm of what is practical, actually, as we move forward. So debating this proposition will be Lucinda for and Holly against. And the specific proposition that I'd like you to vote on are health professions education of the future should promote the use of longitudinal clinical education experiences to the advantage of patients, learners, sites, and academic programs. If you're in favor of that, raise your folder. So if you want to stick your finger in the dike in opposition to this statement, say, please vote right now. Raise it if you think that there are good reasons to continue with block rotations and emphasize that. It's a matter of moral courage. So we'll turn it over to Lucinda.
Well, this will indeed be embarrassing if the vote changes after my after my comments. So let's see. And I did realize after this morning when I reread my remarks that I had stayed way inside the box, so I just apologize for that in advance. So while acknowledging that there are numerous differences across our respective disciplines in the design and administration of the clinical learning component of our curricula, we have in common the goal of maturing the knowledge and skills of our learners through experience with real patients and communities. Further, experiential learning provides opportunities for assessing the student's progression and attaining specific competencies in actual practice. Depending on the nature of the clinical practice, experiential education also offers opportunities for interprofessional education as students observe and participate in care with other members of the patient care team. The literature does support the contention that student learning is at least equally effective in longitudinal experiences, and in some studies has been demonstrated to even be perhaps a bit stronger. Further, the longitudinal model offers advantages to the site, the academic institution, the learner, and most importantly to patients. Our Canadian colleagues have especially identified longitudinal integrated clerkships as opportunities to place learners in rural care environments that are less appropriate for short, perhaps 4 to 6 week rotations given the logistics of student placement. And while many aspects of the traditional academic health center staffing model seem to argue against longitudinal placements, in pharmacy the most well-established longitudinal experience is in fact at your institution in Chapel Hill. And after it was developed there, administrators of the other academic health centers in the region approached the school and requested that the longitudinal system be expanded to include their health systems as well. So given the increased complexity of today's healthcare delivery systems, introducing a student in a clinical learning environment involves a number of administrative requirements, including mandated HIPAA training and security checks, orientation to the now increasing array of clinical electronic record systems, and various policies and procedures of the institution. Allowing a learner to receive such an orientation in a single system for a period that might extend 3, 6, or longer months, rather than the typical 4 to 6 weeks in the rotation model, introduces efficiency for both the learner and the site and provides the learner proportionately more time to engage in learning activities in patient care relative to orientation. Managing the longitudinal placements can increase the efficiency of the academic administrator's work in terms of developing and maintaining relations with clinical education sites. Just using simple math, for 100 students doing 12 months of rotations, 2 longitudinal placements equal 200 placements. 12 one-month-long rotations for that same 100, in contrast, requires 1,200 placements. It's likely that the relationships between the school and the clinical settings where longitudinal experiences are conducted can be developed more deeply based on a premise that the site can integrate the learner into more consistent and meaningful patient care activities under the supervision of clinical instructors or preceptors who come to trust the student's abilities over time. There's also the potential for better preceptor training, especially with respect to assessing our learners. To quote Hirsch, Holmboe, and Tenkate in a commentary just published in Academic Medicine in February of this year, longitudinal models restore educational continuity, both in trainee-patient relationships and trainee-supervisor relationships. The educational continuity in longitudinal experiences should also foster more robust trainee-trainee teamwork and trainee system work, which is, after all, the cornerstones of quality and safety. Thank you.
Just like some of you ignored the rules on PowerPoint, I'm going to ignore the rule on victory. So if I can get one person to think a little differently, I feel good. Okay. As Lucinda mentioned, rotation-based or blocked clinical experience models are used by multiple professions, but they all have different meanings to these multiple professions. Your readings that you were given to prepare for today's session, which you may or may not have referenced in the flipped classroom approach, are all based on the medical model. So most of the remarks today are on the medical model of clinical education. But I want you to know that to nursing, pharmacy, most pharmacy programs, PA, PT, OT, and a multitude of other professions, community-based or block rotations mean something entirely different. For the medical model, it's primarily hospital-based. And the suggestion to move to community-based rotations seems new. However, to the other professions, community-based rotations are part of their blocked rotation schedule. So the traditional rotation-based clinical experience model, one of its best supporting arguments for it is that it's durable. It's withstood the past 100 years in health professions education. Durable, so that's one point. With thoughtful preparation, it may provide greater diversity for the learner in terms of patients, practice models, including the medical home, diversity in preceptors, and sites, including community-based sites, which serves to increase the learner's appreciation for future career decision-making. Additional benefits to the rotation-based clinical experience over the longitudinal model, just one to cross the border here, is that it is more cost-effective. There are no new startup costs, implementation, and maintenance costs when you sustain a major curricular shift and change. These added costs to the longitudinal model in medical education include extensive administrative changes and administrative shifts, moving to a central governance model rather than departmental ownership of the curriculum. A large cost is also faculty development for all these new site faculty preceptors, and reimbursement for all the faculty trainers of the clinical faculty. So it's a very expensive proposition, as well as it could possibly be the new flavor of the month, another drive-by approach to curricular change. Golly, I haven't even got past my first page yet. All right. It's also the blocked curriculum, the rotation-based curriculum could be more efficient. It's logistically easier to track learners achieving milestones and competencies by setting, because the expectations are by setting. The longitudinal model makes it harder to ensure that the minimal number of patient encounters are met. Systems are not organized around learners, and movement to the longitudinal model requires more active participation of the learner and to monitor their achievement of milestones. So if you want to increase appreciation for diversity in health professions education, if you want to increase diversity in practice, then you need to have diversity in your clinical rotations. Thank you.
That's great. So we've got 8 minutes. Comments and questions from the floor. Marilyn.
So I might be your one vote. No, I'm teasing. I would say don't throw the baby out with the bathwater. And I did vote, obviously, on the other side. So the question is, from the block programs, you do, as Holly, you so well explained, the diversity of experience. The student comes in, has no idea of the breadth of experience or opportunities. And if they are only in one longitudinal experience, it limits that ability. So, and I think the other issue is the how might we question. So the how might we question would be, how do you include or add a longitudinal experience while still offering the diversity of experience?
Good. Good comment. Ifaf.
So I might be your second vote. And I'm putting my dean's hat on to agree with you about the expense of a longitudinal approach and the expense of training faculty to do that. Plus, it's really hard to have the sites and the preceptors if it is a drive-through kind of approach. So the block does not preclude, as you said, engagement in the community in a longitudinal way, but the block will provide the depth that the students need in terms of the patients, in terms of the clients, and in terms of the kinds of issues that they would deal with. And the longitudinal might come in through the community-based approach. So thank you both. You're fabulous.
Yes, ma'am.
I love these debates. I just want to appreciate what was said about it's a number of health professions are represented here, and we actually have very different models in our experiential education. In social work, we've done longitudinal forever, and innovation is to block rotational model. And we're experimenting with that. So I realized afterwards that I voted for longitudinal because that's what I think medical education should start experimenting with.
Interesting. Good. Other comments? Questions? Yes, ma'am. Patricia in the corner, and then, okay.
My concern with the longitudinal, although I voted for it as well, so I might be the third or fourth, comes really back to two things, diversity and then also fit, because sometimes a student just doesn't fit in one setting, and then when they don't blossom there, and then they blossom in another setting. So, I mean, it depends on how you structure it, but I think the diversity of experience plus the diversity of practice means that we do have to make some changes sometime.
Good. Marie.
So I wanted to build on Darla's comments in social work, and we too in Canada are experimenting with what's been traditionally longitudinal and moving to rotation, but within the same system, within the same site. So I'm wondering if it's a both and not an either or.
Right. Good. Rick, did you have a?
Well, I'm from Kansas. Some of our best rotations are in rural areas, and the communities these are in, maybe 250 miles from a urban area. I don't see any way that we could do a longitudinal rotation or a longitudinal, organization in those communities, and they're really important rotations for us.
Good. Yes, ma'am.
Linda Kasser, representing the Association of Schools and Colleges of Optometry. Like the other professions, we've had longitudinal rotations for a number of years, ranging from 8 weeks up to 6 months. We typically have had them site-based, so as was mentioned, the diversity opportunities there with community-based, hospital-based, interprofessional environments. I think, though, I'd love to see this group continue the dialogue. Longitudinal versus block to me is not chronology, it's what's happening during those rotations and the emphasis and commitments that they include.
Good. Here, and then somebody over there. I didn't catch you. Okay.
I was just going to say that they're conflating kind of two factors, whether something is longitudinal or rotational, and whether or not it's what we call massed practice or distributed practice. And so it kind of depends on the purpose of the rotation and what is expected to be learned. There are going to be some skills that are going to need intensive massed practice, and there are going to be other skills that can be learned over a distributed time and longitudinally. But the fact that there are two variables that are kind of conflated in this discussion makes it hard to resolve as one or the other.
Good. Thanks. Steve?
Yeah, Steve Shannon, Colleges of Osteopathic Medicine. Just an observation. One of the biggest challenges we face in general relative to clinical education is just the capacity for clinical education. And while I agree there's the reality and the way it should be. And the way it should be, I believe, especially coming from a profession with a strong primary care community-based focus, is a longitudinal clinical experience with opportunities for a variety of diverse type of other experiences. But the current reality we have where so many of us are bumping into each other around clinical training, and the concept if we were really going to say, okay, everybody's got to switch to longitudinal education, I don't believe we'd actually have the clinical capacity to do it. But it's one thing to think if you're making a curriculum change or starting a new school about trying to build that kind of model. But thinking about like flipping the switch raises major issues because I don't think we have the capacity for it, especially in the current environment with the way resources are being allocated.
Good, thank you. Yes, ma'am.
I actually voted for longitudinal, but I agree with what was said a while ago. Deciding whether an experience should be blocked or longitudinal depends on the objectives of what we want our students to learn. The block system would probably be more appropriate for learning clinical skills. But if we're talking about community-based education, perhaps the longitudinal approach would be better. Because if you do block rotations in the community, what's going to happen is you're making the community fit into our academic objectives, what we should be able to do is allow our students to fit into the dynamics of the community. You don't force them to fit into our schedules. We have to be the ones to fit into the schedules of the community where we're training our students.
Good. Last comment, last two comments here.
So I feel this pendulum swinging back, and I want to save Lucinda from embarrassment here, lest things go all the way the other way. So, of course, all of these are false dichotomies, and they were set up that way, and it's, of course, not either or. But if I look at the clinical education as we do it now and say, what is missing, what aren't we doing that we can't do? Of course, there's still a role for block rotations, but there are certain things we cannot do with block rotations. And the things we've been talking about this morning are things we cannot do with block rotations. So if we're going to make changes, I say we have to move more in that direction. And I don't want to see the pendulum go back to the status quo. So I'm for Lucinda.
The final word, Maddie.
Maddie Schmidt. I'm also going to follow up George's comment in support of Lucinda because one of the things that's talked about in the Nexus concept is the better integration of education and practice. And I think critical to that notion is seeing students as value added in the practice situation. And I don't think you can bring that value added experience that is mutual without more longitudinal experiences.
Good. So we will now take the vote. And again, remember, this is the revote. The proposition is promote the use of longitudinal clinical educational experiences to the advantage of patients, learners, sites, and academic programs. All in favor of that proposition. Good. All right. All in favor of the opposite proposition that we need to move around. All right. So now, Lucinda and Holly, you get your chance. So what do you really think?
I think the answer is both. I really do. There are things that we need, and to the last point that Maddie made, the reason why we have zapped clinical capacity for learning is because of the drive-by student who can't do anything in a 4-week rotation that is meaningful and continuous that the institution can depend upon. And so I do think we have to address that. And I think longitudinal is one opportunity. And at the same time, you know, our youngins don't know what they want to be when they grow up, when they get to that point in the curriculum. And so I think we owe it to them to also show them some diversity in the career opportunities that they'll have.
Good. Holly.
I too also feel that a hybrid model is what we need and that it needs to be individualized to the context and the learning competencies that we hope to achieve. It was very hard to prepare for this because of the different language across all the professions. So I think the biggest aha moment for me, which I get these all the time, was how much we can still learn from each other and that we don't all speak the same language, and it's nice to be reminded of it periodically.
Good.
So thank you.
Thank you, Lucinda and Holly. So we're solving all the problems in health profession education in an hour, so we appreciate that.